Hello, everyone. Hi again. If you were on earlier, you would have met me. My name is Tracy Broadhead-Fripp, and I'm your host today. Welcome to Physician Medical Forum's Doctors on Board and Community Health Ambassadors virtual program. It's an interesting time that we're in, and we're excited to be able to share some time with you today. We've got a wonderful program planned. We've got students and doctors from all over the country joining us in all different time frames. So why don't we go ahead and get started? We've looked and seen your beautiful faces, but now it's time to meet our beautiful Executive Director of Physician Medical Forum, Ms. Stefan Bello.
Good morning. Sorry about that. Can everybody hear me now? Carolyn? Okay. All right, great. So I am Stefan Bello, the Executive Director, as she said, of the Physicians Medical Forum, and welcome to our first virtual Doctors on Board and Community Health Ambassadors Internship Program. As you know, all of us have gone through quite a bit of the COVID-19 coronavirus, and of course, we had to move from our 10 years of doing in-person programs to now virtual programs. We hope to have many more in the future, and we hope to try to make them as interesting as possible for you. The Physicians Medical Forum's job, our mission, our goal is to support you in your goals to become doctors. And not only that, but to support residents and physicians in some of their endeavors too, to keep us all healthy. I am proud of each of you. We are proud of each of you, and we want to encourage you because as you can see now, it is so needed to have many doctors, especially doctors in diversity and of many backgrounds. So with that, I'd like to try to introduce our president, Dr. Albert Brooks, who has been made, and would like for him to start. Thank you.
Good morning. Good morning. Is everybody awake? I'd like to welcome you, as Stefan said, to the 2020 Doctors on Board program. We've been doing this program for 10 years, and we're going to do it for another 10 and then another 10. So I want to thank you for attending. As Tracy and Stefan said, this is an amazing and unprecedented time in the USA and in the world. We've got two pandemics. We've got COVID and we have racism. And guess what? You future doctors are the answer to both of those problems. By becoming doctors, I know you will be able to save lives, all lives, but in Black lives, and they're disproportionately affected by COVID. So in fact, you have a special task ahead. The other thing is, by becoming a doctor, is you will help eliminate health disparities in communities of color. So you've got two edges to your sword. We are so proud that you have made the decision to pursue becoming a doctor. The 7 African American physicians on the Physician Medical Forum board know you can do it. So let's have a great day of learning what it's all about and how to do it. Thank you.
Thank you. Thank you, Al. In addition, we have our wonderful Dr. Cara Miller, who's at UCSF, and she is the secretary of the Physicians Medical Forum. We'd love to have her say a few words to each of you students. By the way, Carol, students are coming in on this session from all over the country, as Tracy mentioned, and including Kerry. So thank you.
All right. Thank you, Stefan. Good morning, everyone. I hope you can hear me as well. I too am thrilled that so many of you chose to attend PMF's program for aspiring doctors. My story is likely similar to many of yours in that I come from a family of modest means. My parents were not college graduates. There are no physicians or other professionals in my family, and I certainly don't look like the typical image of a doctor. I did not have role models with whom I could identify, which is why I, along with the other doctors you'll meet throughout the day, are here with you. Role models say, you can do this too. So as you experience the program today, use what you are learning to start the process of creating your personalized plan to becoming a doctor. This should include your vision of why you want to be a doctor, what kind of doctor you think might fit best with your interests, what steps do you need to take, and what questions do you need answered. Consider mapping out your own personal timeline for each step. Create an image in your mind of you as a doctor. Everything starts with the mind. And then return to that image frequently as you move forward to help keep you grounded, focused, and believing that you can do it. I wish you a wonderful day of learning and never stop believing in yourself.
Thank you, Carol. In addition to, this is a little off script, but I think Dr. Navarro is on.
Yes, hi,
Yes.
I am.
Okay.
Hi.
And I was hoping maybe you'd want to say just a few words.
Well, thank you very much, Stefan, for the opportunity. Good morning, everyone. I'm Dr. Renee Navarro, and I am so proud to be a member of the PMF board and to also serve as a Vice Chancellor for Diversity and Outreach and a Professor of Anesthesiology at the University of California in San Francisco. We are just so delighted to have you participate in this program because we are committed and we recognize the critical need for the diversification of the physician healthcare workforce. As the others have said before me, we sit at a crossroads and we recognize that the care to our patients, to all of our patients, is improved with a diverse workforce. Therefore, this hopefully is a great step forward for you. We're here for you and here to support you in your endeavors. Please don't hesitate to take full advantage of this program and to reach out to us. With that, I want you to get on with your program, have a great program, and have a great engagement with us. And best of luck to all of you. Thank you and welcome.
Thank you, Dr. Navarro. Is Dr. McDonald on yet?
Yes, I'm here.
Okay. Dr. McDonald is a cardiologist and he's also on our board.
Hi.
Sorry, my son walked in right as you were introducing me. That's my 3-year-old Ellison. But thank you everyone for joining us. My name is Chip McDonald. Ellison, I need you to go in the other room, please. My name is Dr. Chip McDonald. I'm a cardiologist in Oakland, California. I'm with Stanford Healthcare and Cardiovascular Consultants Medical Group, father of 3. And I just want to welcome you all today. You know, amidst everything, Ellison, please go in the other room. Amidst everything that's going on, pandemic, fires, all the of course, issues with racial injustice, I'm just so delighted to see so many people logged on this morning, this Saturday morning, motivated and ready to get to work on your path to becoming physicians, because we need you. And as others have said, you know, all of us doctors on the telephone, on this Zoom, have had mentors and still have mentors who we've relied on throughout this journey. And so PMF wants to be a resource for you, and we hope that you will take advantage of the resources that are made available through the program. So again, welcome and thank you, and sorry about the the interruption there.
Thank you, Dr. McDonald, one of our future new doctors. Okay. And then finally, I think Dr. Peters or Dr. Kerry, are either one of them on? Okay. All right. Dr. Strudwick? Okay. And then
I'm here.
Okay, could you just say one quick message?
Yeah, I appreciate, as a board member of PMF, I appreciate the opportunity for the interaction with the students. I too am a father, and I'm sure that someone in this program today will probably be my kid's doctor someday. So I fully support your journey as a physician myself, an orthopedic surgeon, and as a dad. So have a great day. Have a great day.
Okay, thank you, Dr. Strudwood. Is it
Steph
Dr.
Kerry moment.
Dr. Peters or Dr. Kerry? Either one of them? Or is Tiffany Slidick?
Dr. Peters is on. I just want to say hi. I'm a psychiatrist, a professor of psychiatry at UC San Francisco, and I welcome you all and have a great day for this program.
Dr. Peters is the president of the Alameda Contra Costa Medical Association. So thank you all. And Dr. Kerry is not on, right? Okay, all right. And Tiffany Slidick from Princeton Review, is she on? Okay, all right. All right, with that said, I think we should move ahead and just have a few housekeeping things I'd like to go over. One, some of you have never participated in our Doctors on Board program. So we want to make sure that you understand that many students have. And so if this is your first time, it's just awesome to try to just listen and absorb and try to follow along, because we will have others, including, as I've said earlier, the mentoring and the sessions, the networking, the mock clinics, the surgical mock clinics, the primary care ones, and so forth. So I just hope that this is as valuable to you as much it is to us in terms of presenting and preparing for you. Finally, I want to say this because we all need to be caring. We all need to be mindful, and we all need to be thankful. And there is a wonderful team that has worked very hard under these very challenging times to put this program together. And so I definitely want to thank, of course, Tracy Broadhead-Frith, who is our MC, as well as Ogoma Ise, who is wonderful and has worked with us and has been our co-chair of our Doctors on Board when it was in person. She is at UCSF and an MD PhD candidate. Donna Tape, who is our web designer and graphics designer. Carolyn Washington and Devonna Hayes, who are both our program assistants. Did I miss anybody? If not, I just want to thank you all, because we couldn't have done this without you. Okay. So with that said, I think we need to move to the next step, and I think it's ready for Dr. Italo Brown in terms of his first workshop presentation. Welcome, Dr. Italo Brown. He is at Stanford University. He's an assistant professor, and he's an emergency medicine doctor. Welcome, Dr. Brown, and would you proceed? Thank you.
Sure thing. Thank you, guys. How's my sound, everyone? Perfect. It's a pleasure to be here. This is an event that I think I'm starting to see how much of a family it really is, and everyone that in the years that I've done this, come across that has attended has had amazing reviews about it, and I've even seen some familiar faces among the participants today. So I'm happy to be here, and this is going to be a pretty a new take on something that we've been doing for a while. So let me go ahead and start the presentation so I can get this going. Okay, so we'll proceed forward. So, all right, everybody has questions about the different types of medicine that you can practice. And this is one of those moments where you have to look deep into your soul and say, like, what is your calling? We know you want to be a physician, but are you familiar with all the different pathways that you can take as a physician to provide care to people who are in need? So it's not as simple as just saying, I want to be a doctor. Go ahead, put some scrubs on me in a white coat, and let's go to work. There are different types of physicians, different specialties, different requirements, and the types of patients that you treat may be up along a spectrum. So we're going to talk this morning about those different avenues in medicine that you can practice, the different disciplines, the things that it takes to accomplish those different specialties, and what's the best fit for you. So hopefully by the end of this conversation, what I'd like you to be able to do is at least have a broad stroke understanding of various specialties within medicine, how medicine works, and how we interact together to provide optimal care for patients. So the first thing I want you to do is stop for a second and ask yourself a serious question when it comes to medicine. Like, what do you want to do? You know, like when you go to sleep at night and you have a dream about being a physician, how do you envision that dream? Do you see yourself in an operating room? Do you see yourself with pediatric patients or children? Do you see yourself delivering babies? Do you see yourself in a dark room looking at imaging? These are things that should be racing through your mind, and not necessarily in the most defined way, but there should be a vague picture that develops when you start thinking about being a physician. So there's some questions that you can ask yourself to help guide along the way. First one I'd say is, do you want to cut or do you not like cutting? You know, some people are freaked out at the sight of blood, the sight of any type of organ system up close. And so that may change what you choose to do. Old versus young versus everyone. So do you like people who are octogenarians or 80-year-old folks who are sweet and love you just for bringing them a pudding cup? Are you more so into the young babies holding somebody who every time they cry, poop, and pee, it is cute to you? I deal with everybody. Doesn't matter what age, as long as they have a medical issue, I can solve it. These things are going to come into play. What if you don't even like people? What if you prefer to look at images or look at cells? Like, those things matter, and it could change your entire trajectory as a physician. Do you want to work inside a hospital, like the TV shows where you're zipping through hallways and taking charts from people and talking to nurses? Or would you prefer to have your own practice and be an entrepreneur and have people come to you and have everything in your own suite? These questions, again, are going to help frame your decision. Now, I know most of you are sitting there. I can see you on the Zoom layout right now, looking like this person in the center here. Now, for those of you who watch Blackish, this is Bo, from Blackish. She is an anesthesiologist, but I mean to take that image of her kind of feeling confused and saying like, all right, you know, this sounds like a lot early in the morning, especially on a Saturday. And then some of you are looking like this person over here, Z, right? And she is interested, perked up. And so I'm going to try to get you guys who look like this person in the front to look like the person in the corner while we discuss this. Now, in terms of understanding medicine and how we've structured it here in the US, there is a clear delineation between primary care and specialty care. So I'm going to spend a couple minutes now speaking about primary care because it tends to be in most places the I guess, foundation of medicine. So primary care, it's that entry point. It's the gatekeeper, so to speak, of medicine. You want to know about primary care because when it comes to the way that things are funded, the way that we develop our standards of care, a lot of it is built upon primary care. And in a time like now, where everybody is going to the doctor to be seen for certain things, primary care as a field is of utmost importance. So, as I said, they're the gatekeepers. They're the people that you come in contact with first. So anytime that you've seen you say, hey, that's my doctor, Dr. Brandwine. I've been seeing him for a number of years. That's a primary care physician. They're usually people who have complete access to multiple elements of your health history. So they don't just treat one issue, they treat multiple issues. And they specialize in continuity, which means that they see you for multiple times throughout a year or throughout a period of time, right? So the same doctor who's doing your physical for 4 or 5 years, the same person who's seeing you for your asthma management for multiple years, that is the continuity that we speak about. The primary care is composed of 4 disciplines, and one of them I'm going to put an asterisk by, but they are internal medicine, family medicine, pediatrics, and gynecology, or particularly OBGYN. But I put an asterisk there because when we get to specialty care, I'll talk about the obstetrics portion as well. So these are defined as primary care because they are essentially like the basis of health and wellness for every type of person, right? And we state that in the US, you should have access to each of these services, each of these particular health fields. They typically take 3 or 4 years of training. The 4 years would be your OBGYN. Everything else is 3 years, and that is at the entry level. From these, you can springboard into other things, but just the basic understanding, 3 years of training, that's 3 years of residency. All of these specialties I named, this is the part where if I was sitting at home, I would take a screenshot of this, is that it's eligible for loan forgiveness. That is huge, right? We just got our loans forgiveness extended through the end of the year. But when it comes to racking up debt in terms of medical school, you want to try to find ways to offset your loan burden. These 4 specialties do that. They give you they make you eligible for a certain loan amount of loan forgiveness. The base pay, as I've shown here, is between 160 to 250K. This is average. It doesn't mean that it's the ceiling of this pay, but this is what we have in terms of published material, and it says that this is the base pay. So let's get on through some of these specialties. Internal medicine. So as you see, I got a picture of T'Challa here, the Black Panther, and notice how he is looking up and he sees everybody. It is village folk, all cascading throughout the mountain or the side of the waterfall. That is essentially how I view internal medicine. They see adults from the entire spectrum of adulthood. They deal more so in not just diagnosing illnesses, but preventing them and trying to manage those conditions. So I mentioned a few earlier, like asthma, but they also do things like diabetes management, high blood pressure management. They can do structured programs for weight loss. They do an entire spectrum of things. And many internal internists have, I would say, extended knowledge in some fields. Like they're very good in baseline understanding of cardiology, baseline understanding of nephrology or renal stuff or kidney things, as well as lung and pulmonary things. So I would say that this is somebody who is definitely invested in the education, in the knowledge of medicine, and the practice of finding out how to fine tune somebody's conditions. They work in both the clinic and on the wards, or they can do one or the other. Now, they do not go to the operating room. That's an important distinction. You're never going to find an internist. If you do find an internist in the OR, they're probably looking for something, and you should tell them to go back to where their domain is. With that said, their hours are pretty flexible. You can see that most internists have either a schedule of working, 2 weeks out of a month, or they cover nights as a hospitalist for a couple of weeks, and then they get a couple of weeks off. Those that work in clinic will say they set their clinic hours and they do those clinic hours consistently. The last bullet of opportunities is pretty important because as an internist, you have to get this baseline or foundational understanding of medicine before you go into things. Earlier, we had a board member who's a cardiologist. That cardiologist had to learn internal medicine first. They had to understand all of these disease and these organ systems and how they interact and the disease pathologies that align with those before going into just the cardiovascular portion of that organ system, or rather. So I think that if you're interested in one of those particular fields, I want to be a critical care doctor, I want to be a pulmonologist, you need to start here. All right. Family medicine. So I have a family here. Some of you may be familiar with this family. It's from the movie Us. I think that it's pretty cool to have representation. But the reason why I put this up here is because you see a spectrum of ages, right? So it's a young kid, you have teenager, you have 2 adults, 1 male, 1 female. So family medicine physicians have that capacity to see everybody. It doesn't matter, whether you're talking about a child or you're talking about an older person, they tend to see that. And they specialize in that continuity of care. Some family physicians, depending on the location, may see somebody from birth through their, well on into their adulthood, right? So think about that. If you're someone who lives or wants to live in a very small, tight-knit community, you can make a considerable amount of money as the primary physician for a lot of people in a small town. They see everybody, as I said. They do the general management and maintenance of people's health and conditions. They can work in the clinic or wards or neither. They can do what I would consider concierge medicine, which is just come to somebody's house, practice medicine, and then go back to doing your thing. They do not go to the OR. Hours, for the most part, are pretty flexible. I would say that most family physicians I know live pretty good lifestyles because they can kind of bend in and out of what they want to do. I know some that do nursing home care primarily and then do clinic on the side. So there's an entire amount of a different amount of combination of things that you can do to make a pretty good lifestyle for yourself as a family physician. Pediatrics. So these are two children, the West children, as I like to call them. They are much older than this picture now. But if you are somebody who, when you first saw this picture, the thing you said was, "Aw," that's probably a good indication that you like kids. And for people who want to practice medicine and help children, being a pediatrician is not only extremely rewarding, but it is probably one of the specialty or the fields that I would say you have an endless amount of patience. Like pediatricians, they see children from newborn to the age 21, and even sometimes older than 21, depending upon where they're at. I think that the cool thing about pediatricians is they do the general health management of children, but also have some special knowledge about certain childhood illnesses, things that most people commonly don't understand. For example, like right now, everybody's talking about how COVID affects people and with going back to school, how that could make a bigger implication on things. These pediatricians are like your experts on that stuff. They know about school. They know about return precautions. They understand the disease processes. So they're extremely helpful, not just to children, but to parents. So think about that. They work in the clinic. They can have wards, which basically, when I say wards, I mean working inside of a hospital where you are doing rounds. So on any medical TV show where you've seen a person walking around and they got like a troop of people, like little minions following them, that is what I would consider the wards, where there are patients who are admitted. And then they don't go to the OR. Some specialists who have pediatric backgrounds do go to the OR, but this is not that case. For the most part, I would say the hours are pretty flexible. I think that you still have to keep in mind that children can get sick at any point in the day, so you almost have to do extended hours in some cases. And there's tons of opportunities to subspecialize. We have pediatric emergency physicians here at Stanford as well. We have any of the major areas of pediatrics, of medicine, like critical care medicine, pulmonology, nephrology. You can be a pediatric specialist in those fields, but the route is to go through P's and not through internal medicine most of the time. All right, another family that we know of. This is Hove and the Queen. So we will say that obstetrics and gynecology is a hybrid. I mentioned it earlier and said that I want to put an asterisk by it because, to me, this is the only specialty where you have the skill set to be both a surgeon and a primary physician. So let's dispel that myth right now. If anyone has ever told you that someone who is an OBGYN is not a surgeon, that is not true. They do perform surgical procedures. They do invasive work. So I want you to know that this is, again, eligible for loan forgiveness, but also has surgical elements to it. They specialize in the complete care of the female patient from top to bottom, from front end to back end in terms of lifespan. I think that most people start seeing an OBGYN in their teenage years. Most women start seeing it in their teenage years and can see one all the way up into like older adulthood. The key here is understanding the spectrum of things that they cover. Everything from just birth control to performing hysterectomies and removal of fibroids or masses and things like that. I think that is important, an important distinction. Can do clinic work, work in the wards, and in the operating room. All of these things are fair game. All right. And I think that the major part when I say lots of opportunities is because there is becoming a new space, or I want to say new space. There's becoming a greater interest in reproductive health, right? So we know that maternal mortality rates are increasing. So that a lot of people are trying to figure out this problem through research. Also, people want to have children at older ages. So doing like fertilization and working on reproductive things are becoming extremely popular and extremely lucrative. So think about that. All right, I'm gonna do a quick check to see if everybody's still with me. Throw me a thumbs up if you're in. Cool, I see you, I see you.
I'm with you.
I love it, thank you. If you talk to me, I'll talk back. All right, let's go. So specialty fields that I'm going to really try to break down. We've just rounded out the entirety of what I would consider your primary care fields. Specialty fields, now this is for you all who, when you laid down at night, you said, I see myself in the operating room, walking in like this, scrub me in, scrub me out, hand me this, that is like the entry point. But there are other specialties that most people don't think about, right? Like, who knew that there was something called an otolaryngologist? Who knew that you have people who specialize in just skin and cutaneous conditions? Well, today we're going to talk about those things. All right. So the main thing about specialty fields is that that specialist focuses on just one particular organ system or specific arc of organ systems, or they focus on just one population. It is the narrowed version of the even narrowed version of the narrow, right? So literally surgical type precision with what they focus on. They typically have some degree of invasive care, meaning that they do something with that organ system that may require a higher level of care, a higher level of procedure. And then because of that, it requires more training. So you're looking at minimum, usually 4 years. And then at the upper limit, you can have as much as 7 years, maybe even more if you do research in the middle of it, right? The base pay is commensurate, meaning that because you spend more time training and because you are so specialized, they are going to break you off. You're going to get more money because of those skill sets. And then finally, the part that is like the major kick in the shin is that they are usually not eligible for loan forgiveness. So I'm going to say that again. This is one of those slides that you should screenshot at home. They are not eligible for loan forgiveness unless you are OBGYN. Cool. All right. Hold on. There we go. So let's start with my favorite person again from Blackish. So she's saying, I make sure people don't die. It's actually pretty true. In the OR, the anesthesiologist is kind of like the DJ. That's how I view it, right? Whereas the surgeon might be the MC, the anesthesiologist is back there on the ones and twos. So they manage the entire care before, during, and after procedure. All right. Think about how much information you need to know and understand about procedures and not being the one that does them. Know about medications that are going to bring a patient to a level of sedation where they don't feel pain or their body doesn't react violently to what's happening on the operating table. And then afterwards, managing that patient so that they come back to a point of consciousness and that their pain is controlled. That is an anesthesiologist's swan song, right? They are usually seeing adults, but can see kids if you specialize in pediatric anesthesiology. All right. They do airway things, which is kind of like what makes them these, what I would consider I wouldn't call them jack of all trades, but these kind of like Swiss Army knife characters, because not only do they manage medicine, not only do they know critical care stuff, they also understand how to get an airway, which means if the patient has difficulty breathing, or if the person needs to go to a procedure and they need a tube placed in their mouth, down their throat rather, to help them breathe or to mechanically breathe for them, they can do that. And they can operate the breathing machine. So the main part about this is they usually do not do clinical work. They specialize in what I would consider OR medicine, pre-post medicine, and sometimes we'll do critical care medicine. So you can have anesthesiologists that also serve as critical care attendings and specialists. They get paid pretty well. I have several buddies who do anesthesia, and when I tell you that I call them and they say I'm on the golf course, I believe it. I believe it. But they also have to wake up right before the rooster does. So understand that if you're someone who this morning had trouble, like my man who's rubbing his eye right now, if you were him, you may want to reconsider. For sure. All right, let's keep it rolling. Dermatology. Staying in the Blackish theme, right? So Yara Shahidi, so known for her immaculate, flawless skin, right? As well as high cheekbones. Well, dermatologists have two things that they can do to help everybody achieve their own inner Yara Shahidi-ness. One is they can give you skincare regimens that are out of this world. Two, they can do Botox. So I say that to say they not only do things that are just general cosmetic, but more so the management of skin disorders. So think about, disorders of skin, hair, and nails. So think about somebody who has like a weird mole or something that they want to have examined. And what if it turns out to be a cancer? What if it turns out to be a rare skin condition? Or you have like very, very bad, poorly controlled, acne. These are people who essentially can change the entire way somebody perceives themselves and the way that other people perceive them. So their power is not just in treating skin, hair, and nail issues. It's sometimes in rebuilding confidence, sometimes in giving somebody peace of mind. So I think dermatology is usually undersold. But if you ask them, that's perfectly fine because they're usually highly intelligent. They perform well on exams. They get paid extremely well. They can pick their own hours most of the time. So I know dermatologists that end at 3 every day, 5 days a week. I see you from 8 to 3, and that is how it goes down. Don't call me on the weekends. We'll see you in the clinic next week. They don't go to the wards. They don't go to the OR. I think I want to emphasize that part about as a field, it is one of the most competitive specialties. So bear in mind that this is like, I would say most competitive, probably something like plastic surgery, then dermatology. All right. Cool. All right. Emergency medicine. There goes my family. So I am biased as an emergency physician. In my mind, it is one of the coolest specialties. So I'm going to try to come from a place that is more midline rather than fully on the side of everybody on this call. All 70-something of you guys be ER physicians. So what I want to highlight here is that the spectrum of things that emergency physicians handle is wide, right? We have to be able to speak the language of every other service and know something about every other service. So you do a little bit of critical care medicine. You do a little bit of invasive procedures. You do dermatology, ophthalmology, ear, nose, and throat. You suture, you reduce shoulder dislocations and hip dislocations. You you splint broken bones. That is like your storehouse. On top of that, you deal with homelessness, substance use, domestic assault, like a bunch of other things that happen to come to the emergency department because all of these issues may require immediate attention. They see everybody, right? So, You can have a pediatric patient right next to a person who's 97 years old. Got to know what to do with both. I'm talking about a 2-week-old baby and a 97-year-old young 97-year young person. I say that it is a hybrid between primary care and surgery because when it comes to trauma care, particularly understanding how to resuscitate somebody effectively and how to do certain procedures that are life-saving, they are invasive, which gives us the distinction of being a surgical specialty. But it is not going to the OR. So let's make that clear. I'm not going to show up in the OR and scrub myself down at all at any point. I chose this life. But if you need me to put a chest tube in to save a patient who's been shot in the chest, I know how to do that. If we're going to do anything invasive to, reinflate a lung, I can do those things. We also intubate patients like anesthesiologists do. So usually airway management is something that's in our spectrum, is in our wheelhouse as well. Very flexible hours. Most ER physicians work anywhere between 8 to 14 shifts a month. That's 8 to 14 days a month. Hours are usually 8 to 12-hour shifts. And so if you do the math, that gives you about a good 2+ weeks of do what I want to do time. The hard part is these hours are not all contiguous, or they're not the same. So you may work nights, you may work midday, you may work morning, you work holidays. So understand that the emergency departments are always open. So you need somebody there who knows what they're doing. But because of that, there's always a job for you. And as you've seen in COVID-19, emergency physicians can have kind of been shifted into a specific light as frontline workers, people who have interacted with COVID-19 at an intimate level. And we'll talk more about that later. But I want you to know that through emergency medicine, there are tons of opportunities. People open their own clinics. They open their own, they do other things outside of emergency medicine as well, work in politics, everything and the like. All right, so this is the homie from Stranger Things, and I don't know if you've seen this scene, but basically she crushes a can with her mind, and that's how I think about neurology and neurosurgery. They are some of the most intelligent people that I've ever come across, and as a field, understanding parts of how the mind works is exciting. It's still the only two fields that I know of for the most part where we don't have a significant portion of it figured out. There's still learning that's happening. So how am I on time, guys? Uh-oh. All right.
You have about 15 more minutes.
Perfect. I think I'm almost at the point of this. Cool. So neurology, neurosurgery, not the same thing. Neurologists, they are the ones that I would say understand the disorders of the nervous system, kind of follow things from, I put here in bread and butter that they will do things like understanding headaches, strokes, seizures, but also really weird conditions with nerve endings, with spinal cord issues. They understand those things. So there are certain conditions where you're like, oh, I don't have sensation on both sides of my arms, or I can only sense heat and not fine touch. They know why people have headaches that seem to never go away. They understand the triggers for different seizures, and they can diagnose strokes like nobody I've ever seen. When those strokes or when those symptoms are so bad that they require intervention or repair, that's when you get a neurosurgeon involved. So while neurosurgery understands neurology, neurology cannot intervene the way that neurosurgeons do, okay? So if there is a brain bleed, both of them can look at the image and say, this is a brain bleed, but only one of them can actually potentially repair that brain bleed. They see adults and kids. Usually pediatric neurologists or neurosurgeons are the ones who treat children specifically. As I said, the bread and butter are going to be those headaches, strokes, and seizures, meaning the most common things that you see. But neurosurgeons, they see tumors as well. So if there's a person that comes in and they have some type of cancer that is metastasized or moved to the brain, or they have a tumor that is just occupying space, causing the person to have conditions and neurological findings, they can actually resect or remove those things, right? if you've ever watched an episode of like one of these TV shows, the doctor or hospital TV shows where they drill holes in the head and release some blood, that's a neurosurgeon that does that. And in some cases, it's an ER physician, but we're not going to go there. All right. Ophthalmology. So my main man and fellow Morehouse alum, Samuel L. Jackson, here as Nick Fury with one eye. I think that ophthalmologists are some of the coolest people I've ever come across. And I think it's mostly because to have such an interest in the organs that allow us to see, that allow us to perceive things, it takes a special person. The other part about it is there's an entire different language that they speak, like literally. If you've ever talked to an ophthalmologist or seen an ophthalmologist notes, it's written in a bunch of shorthand and stuff that if you weren't an ophthalmologist, you would probably have trouble understanding what it said. But their job is to understand all things eye, all things related to the eye, from external to deeper in the neurological processes that are involved with eye issues as well. They have the entire spectrum of things. They can work in the clinic, they work in the OR, and they can go to the operating room. They have very, 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 very good hands. And I say that because in medicine and even in dentistry, there's a distinction among people who have good hands and bad hands. Usually your surgeons and people who do procedures need to have good hands, like steady hands, good fine motor skills. Ophthalmologists have great hands. And then I would say that it's highly competitive. So remember I said plastic surgery, dermatology, right underneath that, ophthalmology. Because mainly their hours are pretty good. You know, you see people in the daytime. That's the first thing. The second thing is you usually don't have to do a whole lot of call shift, which means covering a hospital when in the like in the after hours or over the course of a day. And you get paid very, very well. So ophthalmology is something that I think most people, oh, and let me just add this. I think there's less than 2% Black ophthalmologists in the US. So think about that. If you're interested, like that's how rare it is to find a Black ophthalmologist. All right, orthopedic surgery. Now this is what a large percentage of you people came here for. We had an ortho surgeon on earlier, and I'm sure he will attest to how cool of a specialty it is. It is one of the most popular fields because most people understand the nature of the injuries, but it doesn't stop at just thinking about an athlete getting hurt. It deals with anything in the realm of bones, joints, tendons, ligaments, but they also deal with traumas. They also have really good hands. And so I want people to understand, like, it is not just what the colloquial term is, the bone doctors. They are the bone doctors, but they are also surgeons. So you have to respect them as such. I can see children, can see adults. The cool thing is that they do a lot of manipulation with the hand. So things like placing a cast. Who knew placing a cast was so meticulous? You know, getting the right angles, looking at an x-ray, matching up the bone, making sure that there's proper alignment so that it doesn't grow back funny. And then also understanding the right ways of doing things to not add more injuries, right? But they also do things like, you know, if a joint has an infection in it, they can wash out that joint. They can extract things from that joint. I've seen them manage very, very bad bone disorders. I also think that you have a lot of potential as an orthopedic surgeon to do things like be a team physician, and the possibilities or opportunities are endless because of that, right? You can work in collegiate sports, you can work in any of the sports. They all need someone who has this knowledge, and they get paid well. They will be on the golf course right next to your anesthesiologist. I do believe that the anesthesiologist will be better though. All right, we're on to the last couple of slides. Otolaryngologist and ENT. So this is an ear, nose, and throat doctor. All of those that I can't break down the Latin in that word. I think it's Latin. It's either Latin or Greek. I think it's Latin. But I see ENT anytime I look at otolaryngology. This is a cool field because they do a lot of stuff with scopes, right? So these are very small spaces that you look at a person, like we're looking at Kendrick Lamar right now. I can't see up into his complete nasal passage or in his mouth, but an ENT can come with a scope and then look down into those spaces and can see if there is a polyp, or can see if there is an obstruction, can see if there's swelling, and they can then pass things through to help improve those airways. But they also deal with things like people who have recurrent earaches, ear infections, loss of hearing, difficulty swallowing. All of this stuff is in their wheelhouse, and it makes them extremely valuable. So very well compensated, probably in that list of extremely competitive things as well, and can work in a variety of fields or settings. Pathologists. So we're getting into the spectrum of people who I would say like are not really, really happy to see a bunch of people, but rather see people in the form of their cells, in the form of their the things that are sampled and collected, right? So samples of body tissue for diagnostic forensic purposes, that is your pathologist. If you ever watch somebody say, oh, send this to path, send this to the pathologist, they're talking about someone like this. So there's often several opportunities, not just in the hospital where you're diagnosing types of cancers or benign tumors, but also where you're looking at samples and saying, hey, I think that this sample matches another sample. It could have come from a person who committed a murder. It could have come from somebody from 20 years ago, and we've now solved a case. So this is where pathologists come into play, except they are also doctors. So don't get the DeVry pathologist and this pathologist confused. All right. So the person who's like a crime scene investigator is not this person. Usually stay in the lab. That's where they're at. Right there with microscopes and assays and all types of other cool things. All right. PM&R. I'm going to start to put this on speed because I think I'm down to another 3 minutes. PM&R is about trying to get somebody's range of motion back to where it once was after some type of major injury or condition that causes them to have a reduced amount of range of motion. They want to restore a person's ability and quality of life. Usually see people in the clinic, they don't go to the OR and don't have wards, and you're usually around adults. I think that they get paid extremely well because imagine not having the ability to do something after a major collision, a car accident or something like that. You would almost pay as much money as you can to be able to walk back again, or walk the way you once did, or run the way you once did, or perform the way you once did. And they are usually tasked with creating that regimen to get somebody back to their normal self. Plastics. So I know y'all like these pictures I pull up. Plastics, it is a cool field. Most people think about Brazilian butt lifts and tummy tucks and different type of repositioning of things, but they rarely think about the patient who has been burned or scarred severely and needs skin grafting, or the person who has severe tendon damage in their hands and used to play piano and they need someone who can help them get that alignment back to whatever or preserve what could be left. I think that plastic surgeons not only beautify, but they try to restore, and they can reconstruct things. They can use parts of the body that we never thought about using to build stuff. So there is an element of creation here in sculpting. Extremely competitive. We already know why. That's why you got a bunch of them in Miami that are just balling. They get paid well. And I think that a lot of them have the ability to do multiple things like run a business because it kind of cuts out the overhead for some of them, and it allows them to control more of what they earn. So I think that this is a pretty good feel for somebody who has a business mind, has good hands, and is interested in trying to be creative and help the body reach its optimal condition. Psychiatry. Everything with mental and psychological conditions falls under this field. I want you to know that there's a difference between therapists and psychologists and psychiatrists. Psychiatrists are able to prescribe medications as well as see longitudinally how those medications interact with the patient to see a good outcome. They also are able to see people acutely and determine if they are having psychotic breaks, if they are having any type of suicidal ideation. They have a lot of other medications that they can prescribe to help intervene. Usually, they have very flexible hours, can set their own times, and because they can get paid by the hour and set those rates, they end up being very well compensated. Oh. All right, I think I got two more. Radiology. This is the field for anyone who's like, I want to listen to music in a dark room and look at pictures. This is, to me, I like seeing people, but they see people differently. They see people from their imaging. They see people from when they notice something that is irregular, and then they can tell you exactly how it is. Usually learn a lot about a patient when they call and they tell you, I saw this, so tell me the backstory. Radiologists are needed. Every single specialty needs a radiologist. All right, so that's what I would say. They are in demand, and I don't ever see a situation where radiology is going to go down. Second thing about radiology is you don't have to be at the hospital to do it. So right now, everybody's on these Zooms. This is how radiologists lives. They've been looking at screens for a while. They could be literally in another country reading x-rays and reading CAT scans and MRIs. So if you like to travel, if you want to have that flexibility and want to work from home or work from somewhere where you can be remote, this is your field. But you'll also see a lot of things. You know, you look at pediatrics imaging and find a mass. You'll see a person and diagnose them with something that looks suspicious for a brain bleed. So be also able to understand that they deal with some severe issues as well. Last two, general surgery and urology. Your general surgeon, this is a person who can use, when the body cannot be cured through strictly medicine and giving prescription medications and needs some type of operative management, this is who you call. A lot of times they are doing intra-abdominal procedures, but can do washouts or can do fasciotomies, which means like opening something to relieve the pressure. I think general surgeons are also pretty versatile in terms of what they can do. They can then subspecialize. So you can be a thoracic surgeon, a trauma surgeon, a cardiothoracic surgeon. You can work on specific body parts, right? And I think that they have a wide range of knowledge because not only do they work in the OR, they also manage patients on the floor. So you'll see patients in the operating room and see patients who are admitted to the hospital at various levels of care. So it requires you to be pretty intelligent. They get paid well. And for the most part, it's like whatever procedure you do, you bill for. So the more of them you do, the more that you can bill for them. And urology. So here is a picture of Thanos. He is holding an infinity stone. That is how I view urology. They are searching for the stones. So usually when I talk about stones, we're like kidney stones, right? Everybody's heard of these things. They're super painful. People talk about them in terms of like as painful as like childbirth being the most painful thing people can think of. Having a stone and passing a stone is like probably 1 degree or 2 degrees beneath it. But they deal with the entire genitourinary system. So anything bladder, kidney, ureter, urethra related. I think that people mostly see them as male dominant things, meaning like dealing with vasectomies or problems with how the urethra passes through stuff. But they also, I mean, many women have urologists too. So if you have recurrent urinary tract infections, you might need a urologist, somebody who can help figure out why, and if there needs to be any type of procedure to improve that passageway, then they can proceed and do that. And they get paid a lot. All right, so down to my last couple slides. Lastly, I would say know that each one of these fields we've talked about today, these specialties and primary care fields, has an element of these sub things outside of the box. So this is me saying you can be a doctor and have an interest in multiple other areas within that specialty. So take a look at some of these things and consider them on your slide set. So now I gave you the landscape. What do you want to do? Think about that.
Thank you, Dr. Brown. That was wonderful. We will now, if it's okay with everyone, take a few questions that have been sent in. Let me see if I can get some of these down. Okay. There's a question from Aaliyah. Do dermatologists deal with burn survivors?
Yes. Dermatologists can deal with burn survivors, usually the cosmesis, meaning like the cosmetic element of the burn after the fact, but you're most of the time dealing with a plastic surgeon because of continuity. So plastic surgeons also feel a great degree of responsibility for burn patients. In most hospitals, the burn unit is staffed by plastic surgeons because they have to not only manage the way that the wound heals, but to make sure the patient is adequately hydrated. And there's a bit of medicine that needs to be done. That's what I'm saying. There's a bit of medicine that has to be done as well in the circumstance of an acute burn. But long-term management of a burn, I do think that dermatology can be brought in and talk about certain skin emollients and ways to manage that burn so that it has a better cosmetic finish. But they're not going to do any procedure to correct it. So understand that they're not going to do something like a skin graft or, you know, some type of revision of an already existing graft. That's usually a plastic surgeon.
Okay. Another question from Antonio. If you qualify for loan forgiveness, how much of your debt would be relieved?
That's a great question. You said Antonio?
Yes, Antonio's good
question. So while you guys saying the names, I'm like swooping over to see Antonio's face.
Right.
At any rate, so Antonio, I see you. I got you. All right. It's not, his face ain't on here though. All right. Antonio, that depends, right? So usually I want to be very clear. There are not, what's up, Antonio? Waved. All right. There are usually very few instances where 100% of your loans are forgiven. A few of those ones are, I would say, military. So if you went to the armed services or some sort like that, they do loan forgiveness in the form of service commitment. So you work, however many years you work, you want forgiven, that's how many years you need to work in service, like as that doctor. So not just basic training, but like basic training, and then you become a military officer. You come in at the rank of an officer, and then you provide service as a, let's say you want to go into surgery. So you're going to be a surgeon for 4 years at a military base for 100% forgiveness of the loans, right? Most programs, like the really, really good ones, there's one called, I can't think of it right now. My mind's in 1,000 places. But the most common ones are the government-oriented ones, and they do a percentage of it, right? So you can have like something like 80% is the highest. Most of them are around somewhere like 60 to 70%. Sometimes they give you a lump sum, and you apply that lump sum to your loans, and you can renew it. Then there are research-based ones. So if you perform certain, like if you are an internal medicine physician, go into oncology, like the study of cancer, and then you do research, like clinical research, they have government agencies that will cover a large portion of your loans while you do the research. So to answer your question, it varies. The main thing you need to know is that, one, this entirely could change in a matter of a year. And I know that's crazy, but you've seen what can happen in 8 months. So I'm saying that in the course of a year, the amounts of loan forgiveness could change based upon the presidential administration. And two, that a lot of these loan forgiveness as a state-based thing can change. So some states like California have loan forgiveness based upon what communities you work in. If you work in somewhere where they have a lot of people who are underserved or underinsured, they give you certain percentage of your loans forgiven. So hopefully that answered your question.
Thank you, Dr. Talho,
Yep.
for that. A couple of things. If you, Antonio, send me an email at dob@pmfmd.com, I have some additional actual information on that, and that'll be a reminder, and I'll try to shoot that out to everyone, okay? Okay, this question is from Deshaun to Dr. Brown. Great question. Can you speak a little bit more to the differences in patient interaction / continuity of care in the different pathways? For example, family medicine or anesthesiology.
Got it. Okay. So the term continuity of care refers to the ability to see somebody longitudinally, meaning transition from their first initial interaction with the healthcare system to seeing the same provider multiple times, who has the same level of access to the records and knows the patient. So to kind of paint that picture, I work in the emergency department. If I'm seeing the same person over and over again, that is a problem, right? I should be seeing people for the first time and hopefully the last time, but you may see them again. Continuity of care would be, you are a pediatrician and you saw that child when that child was 2 years old, 3 years old, 4 years old, all the way up to the point when they were 21. All right. So there's a continuity. That person can say, hey, I've grown as a physician with this child. I've seen this child go through a lot of different things. So I know that this child had, an allergy to this medication when I gave it to him because I saw what occurred. I know that this child, comes from a certain type of home. That is why continuity of care matters. Now, it feels like anesthesiology, again, they don't have a patient panel that they go back to and say, oh, this is the 700 patients that I've seen and that I'm seeing this year, I'm responsible for. Their continuity of care is mainly within a short frame of time. So from the moment you check in to get ready to go to you're going to get a procedure done, to the moment you check out. And then most of the time your follow-up is not with anesthesia, it's through whatever service did the surgery. So continuity of care is probably more specific to all your primary care fields, to general surgery, because you have patients, for example, if I do a bariatric procedure, like if I basically put a band on a part of your stomach and help you lose weight, you have to follow up with me. I have to watch you. I have to see that it's working. I have to make sure you're not having complications. So there's some specialties that have that continuity of care, like general surgery. I would also say ophthalmology has a degree of continuity of care. If you're somebody who has a serious ocular condition and you have to see somebody multiple times, dermatology can have some continuity of care too. But for the most part, we're talking about the primary care specialties who are managing multiple issues longitudinally through the course of several years. All right, cool. We got any more questions?
Oh, okay. So we have a lot of questions. So we only have time for one more.
Okay.
What we'll do is we'll try to get answers to some of your questions. So I'm just picking one. And this one here is from Kobe Miller.
Mm-hmm.
Having an M.P.H background.
Dope.
You
Yes.
find that degree is helpful in the emergency room and so forth?
Yes. All right. So I'm glad that you brought that up. I am a champion for public health. I believe now more than ever, you're going to see a vested interest in public health. As you can tell, we have dealt with what is considered the largest public health crisis of the last 100 years, as well as the fact that we're on the brink of vaccine conversations, which is usually a public health, like that is our finger roll. That is our layup. That is our free throw. We love vaccines. So with that, I say, as an ER physician, public health has been like extremely useful for me. And I went the route of going through public health before I went into medical school. So I was already sold on public health and I had to be resold on medicine. With that said, as far as understanding the complete, the context of illness and wellness in America, you can't do that without having a basic understanding of public health. You need to understand that there are social things that affect the way people actually live and their ability to get optimal health. Things like lack of access, lack of education, poverty, I can go on and on and on about the social conditions that cause people to have worse health outcomes. So that understanding and ability to track it is a part of public health. The ability to create interventions and strategies that improve these issues are part of public health. And physicians, people who specialize in being evidence-based and love to try to do the best thing for their patients, have an interest in public health. The two top ways that I can think about, and ways that will appear on exams from now until forever, once you become a physician, is understanding of epidemiology, which is the study of disease occurrences and trends in a general population, and then biostatistics, which is the ways that we can create data to support those trends or to evaluate those trends, right? We make our distinctions based upon, like, every single research article that has to be read by a physician is built on two of the major concepts that you learn in public health, right? If I get a paper that's saying, hey, you should use this medication as opposed to this medication, well, what's helping me make that decision? I'm looking at data. I'm looking at ratios, the odds of it working, how many people improved, how many people got excluded from this study. All of those things are skill sets that you learn in public health. And so that's how I find it most helpful, is because I can break down data and understand the evidence for myself. I don't need somebody to just tell me, throw this medication down. Hey, give everybody Plaquenil for COVID-19. I read the study. I understand the data. I'm not going to do that. So.
Okay. Dr. Brown, we're going to try to do two more questions, maybe quickly to 10:50, okay? And then we'll take a break.
Certainly.
What is the difference between the emergency physician who is an MD versus a DO? If we could get a brief answer on that.
Yeah,
okay.
Wonderful question. Okay. MD, DO, allopathic medicine, osteopathic medicine. Allopathic medicine believe that we can use medications like pharmaceutical medications to heal the body and to make the body do certain processes that are corrective. Osteopathic medicine believes that the body has some intrinsic ability to heal itself, and manipulation of some of those things can improve the body, as well as medications that can assist the body in doing things. Bottom line difference, letters, MD, DO. When I step into a room and I see a DO, I feel just as assured as I do when I see an MD. Because in all honesty, I find that the DOs that I've trained with have to operate with the expectation that people are going to think that they are not MDs. And so they train very hard. They understand the medicine. And I think that more often than not, I find the DOs have had a variety of exposures. Not only do they do things like, write for medications and see patients and can do procedures, they know manipulation. Like, they knew physical manipulation, which means like ways that you can, certain positions of the body that might relieve pressure, might relieve lymphatic systems. So they have a realm of understanding of medicine that we do not train in allopathic medicine. But in terms of opportunities, I don't see a difference. I feel like DOs and MDs are both well respected.
Okay, another quick question from Zariah. Okay, can radiologists take the CT scans, x-rays themselves, or do they just examine the images?
Cool, great question. I like that. So the radiologists usually do not take the x-rays or the CTs or the MRIs. Those are usually techs. I'm sure at one point they did, but it became a process issue. And I'm sure that they figured out that it was more efficient to use the radiologists to do what they do best, which is interpret those images. And you can get an operator or a technician to do the physical work of running those machines. One thing that radiologists do that you did not mention, and maybe because we just don't consciously think about it, is they do ultrasounds, right? So an ultrasound is like a device that uses sound waves to create an image of things that are deeper than the surface of a person, right? So when you put it on the surface of a body, you can see a baby. You can put it on the surface of the belly, and you can see parts of the bladder. You can see the ovaries. You can see testicular infrastructure. And so when I need someone to do something emergently, those radiologists are trained enough to get the perfect images because they see them. They know what the windows and the views are supposed to look like. So they can put that ultrasound on a person who I think is having like a twisted ovary or torsed ovary, and they can view the flow of the blood flow to that ovary to tell me if it is being affected or not in an emergency situation. So with that said, there are only a few specialties that have the ability to use that device, that ultrasound, with that type of expertise. Radiologists are one of them.
Okay, and I think this is a perfect question to end on. This is from Joshua. Edic, I think his last name. What were the main drivers that caused Dr. Brown to go into emergency medicine?
I'm going to put a pin on that question because it is baked into my next 2 lectures. So I think that is going to be better answered as I present the portions around building a personal statement and the portions around interviewing.
Okay, all right, great, thank you. So that'll end our question and answer for this period. We'll, of course, have additional ones with the next 2 workshops. A couple of things I want to remind everyone is that if you complete all 3 of the workshop sessions, Physicians Medical Forum will send you a certificate of completion and some other information if you go through all 3. So don't forget that. We'll email that to you. And so now I think what we should do is maybe take a little break. Everybody can kind of refresh. Dr. Brown can refresh, and we can come back at 11 o'clock. Okay, thank you.